Our first speaker is Dr. Hiba Ibrahim. She is going to speak on degenerative spine imaging, refreshment and updates. Dr. Hiba is a specialist radiologist in open MRI for spine surgery. She was lecturer of radiology in Faculty of Medicine in Shams University.
Assalamu alaikum and good evening, dear all. Again, I welcome you in our spine event, and in this evening, I will talk about imaging of degenerative spine, refreshment and updates. So, is this talk is important? The answer is yes, because it is a major public health problem, and according to statistical findings, it is the second leading cause of physician visits, and it accounts for the third most common cause of surgical procedures, and the fifth most common reason for hospitalization. And we radiologists have many imaging modalities. The most commonly used in this issue are plain X-ray, CT scan, and MRI. Of course, there are many other radiological modalities, but of less importance. I will start by age-related changes, then I will discuss the degenerative disorders of the spine, including X-ray, CT, MRI, and some recent imaging modalities. Then I will give you some differential diagnosis of degenerative changes. I will highlight some post-operative changes because, as I said, these patients will undergo surgical intervention, so we need to assess the post-operative outcome. And finally, I will give you some examples from our everyday practice. So between age-related changes and degenerative changes, what are the difference? Simply, age-related changes are like physiological changes which reflect the biomechanical and biochemical functions of the spine. They are not pathologies. While compared to the degenerative disorders of the spine, these are frank pathologies. So to start with the age-related changes of the spine. And for simplification, I will divide them into changes in the intervertebral disc, changes in the osseous structures, and changes in the ligaments. So what is the structure of the normal intervertebral disc? As you can notice here, the disc is composed of central part, which is the nucleus bulbosus, and surrounded by the periphery, which is the annulus fibrosus. And from the imaging point of view, if we correlate this with MRI, we can notice that the nucleus bulbosus is hyper-intense. I mean, it is bright, it's white on T2, because the major composition of this nucleus bulbosus is water and glucosaminoglycan, which is hyper-intense on T2, while the annulus fibrosus is black because it's fibrous in its composition. Then from these age-related changes, I will move to degenerative changes of the spine, and with the same sequence, I will start with the intervertebral disc changes. Simply, there are many nomenclature for the disc pathology, either disc bulge, protrusion, extrusion, herniation, etc. But if the contents of the disc is bulging or protruding outside the confines of the related vertebra by more than 50% of the disc circumference, this is considered disc bulge. While if it is localized, as you can see it here, it's protrusion. Sometimes this protrusion has a broad base, it is a large protrusion. While if the base is localized and the length of the protruded component is longer than the base, it's called extrusion or herniation. Sometimes this extruded fragment is disconnected from the disc and may migrate cranially or caudally. And in this situation, it is called sequestration. Also, we classify the disc according to the position. If it is bulging or protruding in the center, it is central disc protrusion. If it is towards the neural recess, it is paracentral. And if it is in the foramen, it is simply foraminal, and behind or after the foramen, it is extraforaminal. The bone also is subjected to some degenerative changes, and the modic changes of the bone marrow pathologies are classified into three stages, either modic type 1, 2, or 3. In modic type 1, the changes are following the signal intensity of water. I mean, it is hypointense on T2 and hypointense on T1 and hyperintense on T2. In modic type 2, the signal is following fat, which means it is hyperintense on T1 and in T2. While modic type 3 is kind of sclerosis or fibrosis in which the signal is black in T1 and in T2. Of course, if we added STAIR, this will increase our confidence in the diagnosis, but even without STAIR, we can depend on conventional T1 and T2 for our diagnosis. The ligaments, and most importantly for us, the ligamentum flavum also is thickened, and the most accurate name is buckling of the ligamentum flavum. It is not hypertrophied, and this is a wrong name if we said ligamentum flavum hypertrophy, because it is not a muscle. It's not hypertrophied, it is thickened, and when the ligament is thickened, it encroaches upon the spinal canal and induces spinal canal narrowing. Also, the ligamentum flavum is subjected to element of ossification or calcification. To assess spinal instability, we need to do a lumbar spine X-ray in lateral view with flexion and extension to judge if this vertebra is mobile or fixed, and this is very important for the physician. So to sum up the degenerative changes, if we performed plain X-ray, we assess for the curvature, the alignment, the vertebral body height, the intervertebral discs for their height, and sometimes we can appreciate the vacuum phenomena, which is air inside the disc space. We assess the paraspinal region for any calcifications. And in CT scan, we make use of the three planes, the coronal, the sagittal, and the axial planes. And it's very important here in axial plane to stress on the beauty and the importance of CT scan for any parts defect. CT is excellent in general for osseous pathologies. And of course, I tried to make it very simple and systematic, but unfortunately, not all cases in everyday practice are that straightforward and simple. Sometimes we come across difficult cases in which we have to revise a differential diagnosis and we have to be systematic in our thinking. So let me go through two simple differential diagnoses of degenerative bone marrow pathologies, I mean degenerative modic changes. The first and most important differential diagnosis is spondylodiscitis. So what is the role of recent imaging modalities in cases of degenerative spine pathologies? There are some modalities which are applicable and used already in everyday practice, and some other modalities which are still under research work. Dynamic MRI for assessment of spine motion can be done, as in this example, scanning in static lateral view and in flexion and extension, where we can appreciate the difference of the position of the vertebral body in a case of spondylolisthesis detected only with dynamic study. Also, we can detect variability in the degree of disc lesion when we do dynamic study, and this is a nice example of cervical MRI in a static position where the disc lesions are subtle and not compressing the cord, while when the patient is scanned in dynamic extension view, you can appreciate nicely and very clearly the disc lesions compressing the cord against the buccal ligamentum flavum. The second applicable imaging modality is MRI with axial loading, in which we mimic as if we are scanning the patient during standing, and some patients are complaining of back pain or sciatica only during standing or walking. Some techniques are still under investigation, like MR spectroscopy, and in literature they stated that the lactate level inside the disc is increasing with degeneration, and fat contents inside the bone are also increasing with degeneration. Another technique under research and investigation is the T2 relaxation time, and this technique assumes that it can detect the water contents inside the disc even before it is visible to the radiographer, and accordingly it can measure in a quantitative pattern how much the disc is degenerate. Case of 43-year-old male patient with right sciatica. He performed a lumbar spine MRI, and here you can see L5-S1 disc pathology in axial. It is a central broad-based protrusion, and you can hardly say that it is obviously compressing the nerve root on the right side. Clinically, the patient had right sciatica, and the referring neurosurgeon was sure that there is compression of S1 nerve root. So he referred the patient again for MRI for the lumbar spine with axial loading. And by here, I think I'm going into the end of my lecture, exactly as this year of 2014 is going to end. So allow me to wish you a very happy and pleasant new year of 2015. I'd like to thank you so much for your attention. Thank you.
Our next speaker is Dr. Sibu Kassis. He's going to speak on percutaneous procedures in the management of spinal pain.
We'll try to talk about these things which we are doing in our hospital. So what is the role of percutaneous techniques in the treatment of spinal pain? First of all, there is a three-legged model of pain management in the spine proposed by Dr. Benson in Massachusetts Hospital. It's a three-leg stool model. So these are the pillars of treatment of spinal pain or in pain in general. One is interventions like medication, medical and non-invasive treatment, surgeries and procedures, and the third leg, which is very important, is mind-body connection. So without one of the legs, the stool will not hold and it falls over. So what is the role of percutaneous procedures is somewhere in between, I can say, because the injections is considered interventions like pharmacological treatment, nucleotomy, nucleoplasty. It's some kind of surgery, but it is done through a needle. So which procedure to choose? So we must know that most of the backache is non-specific, about 80%. So there is no specific correlation on the MRI or on the anatomically. And it is probably generated from the soft tissue, muscles, tendons, etc. And the other part, the pain generators may be the facet joints, intervertebral disc, nerves, spinal cord, and of course the bone also can give pain. So percutaneous procedure, we can address the joints, the discs, the nerves by the epidurals, injecting the epidural space, and like vertebroplasty, we can affect the vertebra itself. General consideration for percutaneous procedures. So for me personally, patient's comfort is very important. All the patients are anxious. I don't think somebody likes needles. Everybody hates needles. And they come very anxious in the operating room. So I prefer always to not show the stuff, the needles, etc., to the patient. We get used to see the needles, but the patient is not used to that. So if possible, to prepare everything in advance, not to waste time and to reduce the time of stress for the patient. And it's preferable always to assure that nothing sudden will happen, because most of the time the patient is prone on his tummy and he's not seeing what's happening behind, and he's always expecting something will happen. So it's better to tell him that you will feel me working there, but it's not gonna hurt, because some people, when they think about anesthesia, they think nothing, they will feel nothing. Of course, the touch feeling, all these feelings will remain, but probably the pain will not be there. So personally, I use the smallest size needle. I think this is 27G for the first entry in the skin to do the local anesthesia. And I prefer to inject slowly. Some people, they don't like at all if we inject, it will feel like something is pushing big pressure inside. X-ray protection for the doctor is very important. So the aprons for the neck, we can put glasses also. So when you are taking for the hands, is very important. Either we take X-rays, the hands off, or we can use special gloves, lead gloves. Of course, usually we do, before preparing the field, one X-ray to have the entry point or multiple entry points. It depends, aseptic conditions. So this is, I think, important part of the discussion here, that a lot of patients, they ask us all the time, is it safe? Because I heard somebody died, somebody had paralyzed, etc. So are they safe? This is in Dr. O's show. This was the title, and you can download this and you can see it on YouTube. It's 2 parts. So the truth finally. So we didn't know about it, now we know everything. So they say there, I took snapshots from the video. So 9 million procedures is done in the US yearly. And it is not FDA approved, but of course they are doing 9 million a year. And it can lead to arachnoiditis with severe agonizing patients showing on this, and that they say that 27% has dangerous complications like paralysis, stroke, and death, and 4% of people are died. 4% of people. So if we can calculate that very simply, we can see that 4% from 9 million procedure, that means 360,000 deaths per year in the US. It is incredible, it's not possible. Otherwise, it will be the 3rd cause of death in the United States. So it cannot be true, all these things, okay? Let's take the claims. It's not FDA approved, which doesn't mean too much in reality, for example, because here is the safety announcement. There are very rare cases of major complications, but of course, chiropractic also can lead to death, stroke, especially neck chiropractic, and there are more than 30 cases in the literature attested of death after chiropractic, but it is FDA approved. Anyway, when we go to the site of the FDA, we see the references. We have these studies. They are all case reports. There is no big study showing a lot of people died or have strokes. And what is interesting, I noticed that most of the procedures were transforaminal injections. It can be cervical, lumbar, etc. And what is the mechanism? It's very interesting to know how it can happen. This is very rare. This is a study of 3 cases. So when they did MRI after the accident happened, they showed that there is edema in the spinal cord, so it was a stroke. And the conclusion in this study, which is very interesting, that there are 2, this complication, it can happen with 2 uncommon circumstances. Unusually very low original artery of Adamkiewicz, which is the radiculomedullary artery. Here it goes through the foramen. Usually it must not go under T12. So in the lumbar spine, it must be very unusual. And the second thing, that undetected intra-arterial penetration procedure needle. So usually when you are in a vessel, and most of the doctors doing the procedure, they do negative suction test. These 2 very rare things must happen to have such a complication. We are talking about facet, joint, and medial branch. We're changing the subject now. Okay. So the evidence about it, there is limited evidence to inject inside the joint. Moderate evidence for medial branch blocks. Moderate to strong evidence for radiofrequency neurotomy of medial branch nerves. So the strongest thing is medial branch blocks and neurotomy. So this is why the trend is to favor medial branch blocks rather than intra-articular facet infiltrations. So facet joint medial branch infiltrations, indications is arthritic pain from the joints originated from facet joint or sacroiliac joints. Symptoms are basically mechanical back pain or buttocks pain, usually unilateral. It can be bilateral also. More at morning time, improves with moving on. Worst on extension, rotation or tilting. Usually improves a little bit with non-steroidals. The signs, limited and painful range of motion on extension or rotation or tilt, and positive deep finger pressure. So joint pain can be simply axial pain, or it can be also referred pain going down, but usually it will not pass the knee level. There are 2 branches for every joint, the one above and one below. We need to address both of them. For example, to block L5S1 joint, we need to do the L4, which is the one on the right, and the L5, which is on the lower one. Of course, it is done little beyond 15 degrees of rotation to see the junction between the transverse process and the facet joint, where is the middle branch. Of course, this was the cervical and the left side, and we are talking about the lumbar there. So an example, 64-year-old gentleman, neck pain, occipital headache, left C2, C3 facet syndrome, skin marking. We need to go up and down. This is the lateral, this is the So for the injection, you don't need 100% to be over the nerve. If you are nearby the nerve, the medial branch, the drug will diffuse and you have the block test. So the radio frequency can be considered when the test is positive, the patient improves a lot, and we need to have longer lasting results. So we need to target the nerve there. Usually we use insulated needles, so it is isolated, only the tip which is metallic conducting the electricity or the pulse. These are the anatomy, the places where the nerve branch, and there are some, not controversies, some people prefer for the cervical spine prone, some people lateral position, some people use curves, some people 2 straight needles, some people, most of people do stimulation with, or without stimulation. So the stimulation, usually we do sensory stimulation to see if we are really near the nerve. So if we are at 2 millimeter, maximum 3, near the medial branch, the patient will feel symptoms, pain, similar to what he has in general. And this is a good sign. That means that we are near the nerve. So after that, we can inject the local anesthesia and do the burning. The motor is basically, when we stimulate, we see the multifidus muscle in the lower back, and this muscle are moving, twitching a little bit. We are sure that we are not near the nerve root and not having anything in the limbs.
The next speaker is Dr. Abdul Karim Masadi. He is going to speak on update in the management of spine metastatic disease.
Good evening, everybody. I will talk about something which is a subject which is very important nowadays, because we know that the population is going more and more elder, and due to many factors. And as you can see, the spine disorders in elderly, the metastatic disease represent the 3rd common pathology in elderly. And we know that we are going older, and especially in the Western societies, the elderly people represent, they will represent more than 25% of the population in 2020. Spinal metastases are more prevalent than other spinal tumors. 70% of cancer patients will develop when they will get spinal metastasis. 10% of cancer patients develop metastatic spinal cord compression. 95% are extradural lesions. 0.5% are intramedullary, but the rest are intradural extramedullary. The breast is the main origin, followed by the lung and the prostate. The mechanism in general is hematogenous, and we have the direct spread again in many cases. The thoracic spine is the most symptomatic part, and it represents in general 70%. And the peak incidence is between the 4 to 6 decades, with men more than women affected. Even with the breast cancer is the dominant. Spinal metastatic is the most commonly encountered tumor of the spine. You have here many reviews in the literature showing how it is, the incidence and the epidemiology and the frequency. And in some lectures, some literatures, they are talking about 40% of cancer patients, and I showed you the first one, which was talking about 70%. The investigations are in general conducted by the oncologist, but we have some specific marker for the prostate and for other cancers. The imaging is important part of the diagnosis, with the MRI dominant, which is the gold standard. And as Dr. Hiba showed you, you can get nowadays whole spine MRI. And with this whole spine MRI, you can see the multiple localization, and you can show the spinal cord compression, nerve root compression, or others. And in addition to the fresh fracture, old fractures, and the involvement of the spinal canal. The CT scan is excellent for detailed bony evaluation. Again, it is as important as the MRI, because you are talking about bony structures, and the CT is very accurate for the bony studies. So it can replace even the MRI if we have contraindications, and we can perform CT myelography if we are suspecting any spinal cord compression or mass intra-spinal mass. And it is, again, helpful to do the investigation for to scan the whole body and the whole body or the chest and abdomen. 26% of early metastasis can be missed if we are relying on the X-ray alone. The X-ray are helpful to diagnose the instability, to diagnose the deformity, to show the bony destruction, sclerosis or lytic lesions, and even the large mass. We can see it, and you know that sometimes you can see even on the X-ray if you have both disease in paravertebral area. So even if we have large mass, you can see it in the X-ray. The Frankel classification of neurological deficit, when you have severe neurological deficit, again, it is limiting the benefit of the surgery, and especially if you have complete paraplegia, there is no benefit of the surgery in general at all, except if you are preparing, but it depends about the survival rate. So you need to take the whole systems together. You need to take the whole system together. I mean, the four classification. So what about the instability? So we know that about the biomedical principle in spine instability, we have the posterior tension band, and we have the load on the vertebral body, which is representing 80%, and the load on the facet joint and the posterior column, which is representing 20%. We need to take in consideration the things when we have compression fractures, when we have instability. So the spinal instability neoplastic score, which is recent, which is done by a big group of spine oncology study group, which is represented mainly by spine surgeon and oncologist. So surgery is preferred to be done before radiotherapy, and we know as a surgeon, when you are treating and when you are operating a patient who had previous radiotherapy, you have a problem with the healing of the wound. So that is one of the reasons. And the other reason, again, it is the radiotherapy also appears to be less effective when epidural spinal cord compression is associated with the paravertebral soft tissue mass. So surgical decompression and ablation is recommended before the radiotherapy. There are other techniques described in the literature and still practiced about, like the radiofrequency thermocoagulation ablation, which is well known for the osteoid osteoma, and it is good for small limited metastasis inside the vertebral body. And with the when you are killing and ablating this small tumor, you can even inject the vertebroplasty.